No, I just was going to guess most of these people are from the Washington Academy of General Dentistry.
Well,
IAG.
we've really had good participation from all over the place. You know, our friends up in Canada, the Canadian Academy of Restorative Dentistry and Prosthodontics.
Yeah.
We've had over 1,500 Canadian dentists on these webinars. So.
Oh, terrific. Well, as
yeah.
you know, I was going to get to be with you guys and in the fall in Halifax.
Yeah.
And
yeah,
unfortunately, no longer.
No, exactly. Yeah, Dr. Fling and I, we were supposed to speak as well, and we were going to do a little bit of a trip around Nova Scotia there with the wives, and that's not going to happen now.
No,
all righty.
Maybe in a couple of years. Hopefully, it's going to be 2022, though.
Yeah, absolutely. Okay.
I'm going to take off a minute and go tell my ladies in the office what I'm doing so they don't come in and bug me.
Okay, that sounds good.
I'll be back.
Thank you.
Dr. House, we are live and recording. I'm going to turn you over to host.
Okay, thank you. Good morning for those of you that are just getting into the webinar here. Welcome. It's May the 4th, and may the 4th be with you. Star Wars Day, so fantastic. We've got a great lineup of speakers today. This is the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series, and today's is actually sponsored by the International Academy of Nathology. So they've put together the 3 speakers today. The speakers are Dr. Bill Robbins, followed by Dr. Neil Grissetto, and from Australia, Dr. Tom Giblin. So we've got about anywhere from 5 to 6 hours of CE for you here today, depending on how much time our speakers want to utilize. You'll notice that there's flyers going by with QR codes on them. You can use those QR codes to register for any of the upcoming webinars. This week, we have 14 webinars lined up. We might slip one additional one in on Friday, not sure yet. We're also putting together some webinars for next week that are going to be really focused on going back to work. They're going to cover topics such as PPE. We've got Dr. Marcus Trosch from Germany that's going to be speaking on PPE and aerosol. We just have to figure out whether that's Monday or Tuesday next week. We're also going to have a webinar that focuses on getting your equipment back up and running, everything from shocking the lines to what we should be doing for turning the rooms, etc. So we're working with Patterson Dental on that. We are going to also look and see if we can put together a suicide course and opioid course to help people that weren't able to attend the PNDC this year because of the cancellation. See if we can get you those mandatory CE credits. That's up in the air right now. We don't have a definitive date and speaker on that, but we're going to try and do that before May 18th. So welcome. This is the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series. We've done over 35 webinars so far, and I want to emphasize that everybody that is speaking for us has agreed to do this for no honorarium, so we appreciate the kind donation of their time and expertise. We'd like to thank Comet USA, Patterson Dental, the Canadian Academy of Restorative Dentistry and Prosthodontics, Seattle-King County Dental Society, Pierce County Dental Society, Snohomish County Dental Society. Our major co-sponsor with the CE is the University of Washington School of Dentistry CE Department, and you will be receiving CE credit coming from the University of Washington, not coming from the Washington Academy of General Dentistry. You'll receive an email just kind of verifying that you attended this webinar, and that will come from the WAGD. That is not your credits. Your credits will come in a few days from the University of Washington School of Dentistry. There will be a PDF that you just put your name in, and that CE credit will be based on how long you've been on each webinar. The Zoom platform tracks it, and so we don't need to do that. For those of you that are AGD members, we will report your CE credit directly to the Academy of General Dentistry. Those CE credits should show up on your transcript within 2 to 4 weeks. Obviously, everything is backlogged at this with the AGD right now. There's a lot of things they're trying to get on top of. So just be patient with those CE credits. Today, again, is International Academy of Gnathology Day, followed tomorrow where we have the Arkansas AGD that have put together our 3 speakers. And on Thursday, the Canadian Academy of Restorative Dentistry and Prosthodontics have put together our 3 speakers on Thursday. So lots of great CE coming up. Please, you'll see there's flyers going by. Use those QR codes or go to washingtonagd.org. If you go to washingtonagd.org, look for the Stay Home, Stay Healthy CE logo and just scroll down. Most of those course offerings there are free webinars that are being offered, but there's also some of the upcoming CE courses being offered by the WAGD in coming months. We are getting innovative with how we're offering CE. This past Friday, Saturday, we did a virtual hands-on oral surgery course with Dr. Carl Corner, which was interesting because what we did is we shipped out models, hand pieces, and instruments to the attending dentist, and we did a virtual Zoom meeting where Dr. Corner could actually monitor what the participants were doing and work on the models that he's created. So kind of some neat stuff, and we're looking at doing more of these virtual CE events in the future. We're getting close to start time here. People are still trickling in. We'll give it a little bit more time. For those of you that are not familiar with the Zoom interface, use your cursor, scroll around. You can see you can change from a speaker view to a gallery view. When Dr. Robbins is speaking today, you'll be able to resize his PowerPoint so you can see that, and you can shrink the other panelists that are on this webinar today. We are not going to be using the chat feature for Q&A today, but rather we're going to have you put questions in the Q&A feature, and what we'll do is we'll sort through those, and at the end, if Dr. Robbins has some time, we'll hit him with a few questions. So want to thank our panelists, Dr. Gary Hayamoto, who will be monitoring the chat and Q&A feature today, as well as our Executive Director, Valerie Bartoli, for putting all these webinars together. Appreciate that. Thank you, Dr. Pressett, for your webinar expertise. If you happen to miss something with today's webinar and you want to see it, it will be going up on YouTube at Washington Academy of General Dentistry, and that'll be up in 3 or 4 hours. We're going to leave that up there for a couple of weeks until we get through this COVID-19 kind of off time, and after that, that will come down. But you could likely have your staff members or colleagues can watch those webinars that have been recorded. Unfortunately, if you watch on YouTube, we cannot give you CE credit. We're not capable of doing that. So just about time to start here. Let's see how we're doing with numbers. Good. We're a little over halfway there with our numbers that have registered for today. Welcome. It's May the 4th. Like to thank you again for joining us at the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series. This series is co-sponsored by the University of Washington School of Dentistry CE Department, the Canadian Academy of Restorative Dentistry and Prosthodontics. It's sponsored by Comet USA, Patterson Dental, Snohomish County Dental Society, Pierce County Dental Society, And let's see. Oh, Seattle, Pierce, and Snohomish County Dental Societies. Thank you again to Omni, the Braze, everybody else that has contributed to these webinars. This is free CE that is being brought to you by the Washington Academy of General Dentistry. Your CE credits will come from the University of Washington School of Dentistry CE department. Those will be emailed to you in PDF format in a few days. Please do not email the Washington Academy of General Dentistry asking about CE. We're not issuing those CE credits. You'll see some of the flyers that are going by are actually lectures that we had last week. Just a reminder of our great speakers that have helped us out, and their webinars are available at YouTube, and you can get to that via YouTube or go to washingtonagd.org and just look for the YouTube symbol there, and you can click on that and you can see an offering of 35 webinars that we've done so far. We've got another 15 or 18 to go here. So thank you, International Academy of Nathology, for putting today speakers together. We're going to start with Dr. Bill Robbins here in just 2 minutes. And then we have Dr. Neil Grassetto from Harvard speaking next. And then Dr. Tom Giblin coming to us from Australia. So pretty exciting that the IAG was able to put these speakers together. Remember, the International Academy of Nathology's next meeting is going to be in Seattle in 2021, and that's fall of Seattle 2021. So go to their Facebook page for more information.
Oh,
Like your video.
oh, thank you. Sorry about that. Can you?
All righty, Dr. Robbins, it sounds like you're ready to go there.
I am indeed ready to go.
And I'm excited about your lecture today. What's the title again?
The title is My Failures and Lessons Learned. So I'm going to be talking about some failures today.
You know, it's interesting. Dr. Fling, I told him about what you were talking about, and he said, how long did you give him? And I said, 2 hours. He said, that's not enough time for all Bill's failures. So it's nice of you to condense them down. So
can you give me back the screen?
I'm going to give you back the screen in just a second. I'm just going to read your bio here and we'll get rolling.
Okay. Perfect.
Dr. Bill Robbins maintains a full-time private practice and is an adjunct clinical professor in the Department of Comprehensive Dentistry at the University of Texas Health Science Center at San Antonio Dental School. He graduated from the University of Tennessee Dental School in 1973. He completed a rotating internship at the Veterans Administration Hospital in Leavenworth, Kansas, and a 2-year general practice residency at the VA Hospital in San Diego, California. Dr. Robbins has published over 80 articles, abstracts, and chapters on a wide range of dental subjects and has lectured in the United States, Canada, Mexico, South America, Europe, Middle East, and Africa. He co-authored a textbook, Fundamentals of Operative Dentistry, a Contemporary Approach, which is published by Quintessence, is now in its 4th edition. He recently co-authored a new textbook, Global Diagnosis, A New Vision of Dental Diagnosis and Treatment Planning, which is also published by Quintessence. He has won several awards, including the Presidential Teaching Award at the University of Texas Health Science Center, the 2002 Texas Dentist of the Year Award, the 2003 Honorary Thaddeus V. Weeklew Fellowship Award from the Academy of General Dentistry, the 2010 Saul Schluger Fellowship Award by the Seattle Study Club, the Southwest Academy of Restorative Dentistry 2015 President's Award, and the 2016 Academy of Operative Dentistry President's Award of Excellence. He is a diplomate of the American Board of General Dentistry. He is the past president of the American Board of General Dentistry, the Academy of Operative Dentistry, the Southwest Academy of Restorative Dentistry, and the American Academy of Restorative Dentistry. Whew, that's quite the CV. Dr. Robbins, I still remember the first time I saw you speak, and I was blown away. And, you know, this is a tremendous honor for me to be able to introduce you, to be able to call you a friend. And boy, that time we spent in Canada, you know, over the years there, way back, it's just been a pleasure to meet you. And welcome, sir.
Thanks for the nice introduction, Tim. I really appreciate it. And it's an honor. It really is an honor for me to be here today. And, you know, when you listen to a person's CV, obviously it's a bunch of stuff that they've done. So what I'm going to do is sort of take the other side of that coin today, and I'm going to humble myself before all of you and talk about my failures. So let me share my screen. Tim, I still don't have the ability to share.
You should, yeah. Let me know if it's a problem, and I'll make you a co-host here.
Yeah, I can't. There's no place. There's no green
Okay.
button for me to share.
Let me do this. Let's see what happens. Okay. Did that help you out at all?
No.
Okay. Let's see. We've had troubles with Max before. I'm going to share my screen, and then I'm going to unshare it.
All right, now I think it might work. Okay, let's see. So I've got to share the screen now. So let me try it. Yeah, that's going to do it.
Perfect. Yeah, that's got it on our side. I'll mute myself unless you need me.
All right, so we good?
We're good, sir.
All right, let me see if I can. Yeah, excellent. All right, so. Oh, now it's not forwarding for me. Now it is. Okay, so I think we finally got our technology going. Thank you guys, everybody, for coming, spending a couple of hours with me this morning and afternoon for some of you. It is indeed a pleasure to be with you. Before I get started, I want to show you a picture of my father. He's no longer alive, but he was a dentist, and he practiced in the state of Arkansas for about 40 years. And I love this photograph. It was taken of him on the USS Barnes, which was a Navy ship in the South Pacific in 1944. And I always start my lectures with this photograph for two reasons. First of all, I'm proud of him and what he did for our profession, and this is a way of honoring his memory. But the more important reason I always start with this photograph is because he stands for a group of people in my life that have been my mentors. And I am not smart enough to figure out all the things I talk about. So I've hung out with a lot of smart people like Tim and others and learned from them. I've taken their courses, I've read their literature, and I have tried to incorporate what they've taught into my practice and into my teachings. It's always important for me to say to you today that the information I'm going to share with you is not original with me. I'm just a link in the chain of a bunch of smart people that came before me. One of my most important mentors is Dr. Jim Summit, and he's known to many of the people that are listening today. And one of the things Jim taught me very early in my career is that success is a poor teacher. He said, always photograph your failures. He said, it's not pleasant to do, but always do it, because someday you might figure out why the failures occurred, and having the photographs will really help. So that's really what today is about. Today is about my failures. And so I underline my because they're all mine. Everything I'm going to show you that hasn't turned out so well is my stuff. I've been practicing now for 47 years. So that would make me one of the older people on the webinar today, which has given me a lot more years to fail. So here we go. The first lesson based on failures is related to communication with the orthodontist. And over the last 20 years, the orthodontist has become among the most important people in my life other than my family, because doing interdisciplinary dentistry today is essentially impossible without the help of an orthodontist. And the orthodontic movement that I ask for most often in the adult wear patient, and when I refer to an orthodontist, it's only adults. I don't treat children. They're not even welcome in the waiting room. So I'm only talking about the adult, and generally it's the adult wear patient. And when I refer this patient to the orthodontist, I want the teeth to be moved in fairly precise positions. And so how do we communicate with the orthodontist where that position is? Traditionally, I used a technique called a mock-up at the end. I'm going to show you that. Today, I'm using pre-orthodontic bonding or intermediate orthodontic bonding, and I'll show you that also. So let's start out with the way I did it traditionally for many years. So I have a patient, and we look at her, and those of you who know me know that I'm going to do a global diagnosis on her. And her primary global diagnosis is going to be dentoalveolar extrusion with wear, because her gingival line is concave. And once I have a diagnosis of dentoalveolar extrusion, I have 3 primary treatment options for her. The first is functional crown lengthening, and I don't want to do that because that's going to put my margins up on roots. The second is restoring an increased vertical dimension. I don't want to do that because I'm not restoring her posterior teeth. So that leaves me with the third primary treatment option for dentoalveolar extrusion, and that's orthodontic intrusion to level. So that's our goal, to level these and level and align these teeth in order for me to do porcelain veneer restorations on the upper and lower anterior teeth. So the patient is in ortho, let's say, for 18 months, and towards the end of 18 months, she comes back to me because the orthodontist says, I think she's about ready to be debanded. All right, it's impossible for anybody to look at this patient and know if her teeth are in the correct positions to be debonded and restored. So that's where she started, at some place that was not possible for me to restore her. And hopefully now at the end of ortho, she is in a position that I can get anatomically correct teeth coupled at a good interincisal angle with a good AP occlusal plane. That would be my 3 goals as I proceed with the restorative dentistry. So what I would do in the old days is I would do a quick mock-up near the end of ortho to see if the teeth are in the right place. So I would take a bolus of composite, put it on the maxillary central incisor, and freehand an anatomically correct upper anterior tooth. And I would, if there was tooth structure missing on the lingual, I would replace that. If it was incisal loss of edge, I would replace that. So in 2 or 3 minutes, I've now created an anatomically correct maxillary anterior tooth, and I light cure it. I now do the same thing on the bottom. I put a bolus on the lower incisor, and I make it come out the long axis of the tooth, and I make it appear anatomically correct. And while it's still soft, I have the patient bite into it. And when they bite into it, it looks like you see in the middle demonstration, and that is the composite is squeezed back to the lingual. So I remove half of that composite, I straighten it back out, and have them bite again. I continue to do that until the composite is coming out the long axis of the tooth and it's touching lightly the lingual surface of the maxillary anterior tooth. Once I get that done, I now have the patient open, I light cure it, and now I've done my mock bonding. Once the mock bonding is done, I'm looking at 2 things. The first thing I'm looking at is how tall does the lower incisor have to be to couple with the opposing tooth? And the second thing I'm looking at is it aligned with the posterior occlusal plane? Is the new incisal edge position going to work with the posterior occlusal plane? There are 3 possibilities that this mock bonding can tell me. The first is that the tooth is in exactly the right place. It's coupled correctly with the lingual of the upper, and it's exactly on the posterior occlusal plane. So that's one possible outcome, and that's a correct position. The second possible outcome is if the incisal edge is too high. In order to couple with the opposing tooth, it's got to be above the occlusal plane, which would result in a convex occlusal or incisal plane if we deband the patient and restore today. The third possibility is that when it's coupled, there's not enough room to bring the incisal edge up to the occlusal plane. So if we restore the patient at this position, we'll end up with a convex incisal plane, which is very anesthetic. So my purpose was to do a mock bonding to let me know in my communication with the orthodontist if we needed to do more or we're ready to deband and move on to restorative dentistry. So in this specific patient, when I did the mock bonding, as I've described, we can see that the incisal edge is not tall enough to be on the posterior occlusal plane. So what that means is that if we deband the patient and restore them as the teeth are now, we will end up with an incisal plane that is convex. And I'm sorry, concave. And that's an unpleasant look. We don't want to do that. This is the way the porcelain veneers would look if we debanded and restored today. We don't want them to be curved down. We want them to be straight across. So I would then communicate with the orthodontist. I would call him up and I would say, you know, I can't restore the teeth where they are right now because I'm going to end up with a concave incisal plane of the lower incisors. So there's 3 ways we could correct this. We could intrude the uppers to make more room. We could flare the uppers to make more room, or we could retract the lowers to make more room for the incisors to be taller. In this circumstance, I like the position of the upper anterior teeth, so I asked the orthodontist to retract the lower incisors. So that was my communication. So the patient goes back to the orthodontist, and the orthodontist makes his or her bend in the wires. And the patient comes back to me 6 weeks later. And what do? I do the same mock bonding again. And in my experience of doing this through the years, things would be better, but they still wouldn't be right. And I would tell the orthodontist, it's better, but I still need this movement. And what is the orthodontist telling the patient? They're telling them, your ortho's done. And the patient is sick of it. So I am the villain in this novella that I'm describing to you. I'm the one that's continuing to say, we're not quite there. And what generally happened is that eventually we would give up. The patient had had it, the orthodontist had had it, and we would give up. And we would then have to compromise. The patient had been in ortho for 20 months, and right at the end, we couldn't quite get it together. The teeth are in reasonably good positions, but they're not in the correct position. And so in this specific patient, when we did the restorations on her lower incisors, you can see that she's got a convex profile. The teeth are not on posterior occlusal plane. They're above posterior occlusal plane. So this was a compromise. This is another patient. I treated exactly the same way with just the opposite outcome. Instead of being up on occlusal plane, we can see that they are convex. The incisal plane is convex. Once again, the patient went through a lot of effort to get everything just right. And at the end, we gave up because we couldn't quite get it where we wanted it. I did it this way for years, and I look back and think, how stupid was that? Because we don't do it this way anymore. Today, we do either pre-orthodontic bonding or intermediate orthodontic bonding. When we first started doing this about 10 years ago, we generally would do intermediate. The patient would come in, we would diagnose what their case was going to be, the restorations they would need at the end. The orthodontist would place the brackets and start the ortho. Halfway through the ortho, we would then take the braces off, do the bonding, and then put the brackets back on to finish the case. Today, most of the time, we do pre-orthodontic bonding. We do the bonding before the braces ever go on, and it serves 2 purposes. First of all, it excites the patient because they generally have short teeth and we're going to make them longer. So they're going to be happy with the way things look immediately. The second thing it does is it tells the orthodontist exactly where I want the teeth to be at the end of ortho. A lot of orthodontists don't like to do adult ortho. And the reason primarily is because it's harder to do, because we're trying to move worn teeth into correct positions. It's more fun to have anatomically correct teeth to move around, and that's why children are easier to treat, because their teeth are not worn. They're anatomically correct. So essentially what I'm doing in the adult wear patient is I'm turning them into a child. I'm making their teeth anatomically correct, so this becomes much more straightforward orthodontic treatment. So here's our patient. We're going to be doing a lot of things on him, and ultimately he's going to have a lot of restorative dentistry done in his mouth. So we go through all of the pre-treatment planning that we've talked about, and then ultimately we're ready to start the case. So this is the morning that I did the pre-orthodontic bonding. And I'll go over that technique in a moment. So there's the patient before, and there's the patient after the bonding's been done. And you say, well, now the back teeth aren't going to hit. He's only touching on his front teeth now. And you're absolutely right. And we'll talk about how we manage that. So there's my diagnostic wax up. You can see the teeth are not aligned. We're not realigning teeth with a composite. All we're doing is making them anatomically correct. So we've done in the mouth what we did with wax in an analog way. So there's our patient in the morning. At the morning, I'm done with the bonding. And so in the afternoon, the orthodontic appliances go on. And as I said, after the bonding, the teeth never hit correctly because it's not our goal to make the teeth hit correctly. That's the orthodontist's job. My job is to make the teeth anatomically correct. So the two ways the orthodontist can manage the fact that the teeth aren't hitting is we can do what's called a turbo. And I'll show you that in a minute in the front. And a turbo there are little composite ledges that are put on the linguals of the upper anterior teeth to hit only in the front, which then really makes the orthodontics much more predictable and easy. The other way to do it is to add composite on posterior teeth. So that was pre-orthodontic bonding. Let me show you another way that we still do it today, and that's intermediate. The reason we didn't do pre-orthodontic bonding on this patient is because she had vertical maxillary excess and her teeth were really low in her smile. And if we would lengthen them to make them anatomically correct, they would have even been lower in her smile. So in this patient, we chose to do ortho first, halfway, remove the anterior brackets, and then and then do the bonding, and then come back and put the ortho appliances back on. So once again, we're doing this in an analog way. So we're going to make an impression. We're going to have a cast. We're going to do a diagnostic wax up and make a clear matrix that we can cure through. So now we try the matrix in the mouth to make sure that it fits, and we're ready to do our bonding. So I'm going to isolate the teeth and do them one at a time. I'm going to etch, prime, and bond. I'm going to take composite that's been heated in a composite warmer and put it into that maxillary central incisor in the matrix and seat it over the tooth. I'm going to light cure that. I'm then going to remove the matrix and finish it with traditional composite finishing techniques. So there's that tooth completed. I'm going to go to the next one, and over the period of a couple of hours, I'm going to do the bonding. So here's the patient at the end of the bonding. The teeth are now anatomically correct. She goes back to the orthodontist. The orthodontist puts appliances back on. These are the turbos that I mentioned. So this is what the orthodontist can put on the linguals of the maxillary central incisors that act as ledges to disocclude the posterior teeth. That's one way to manage the fact that the teeth aren't hitting correctly. The other way is to add composite on posterior teeth, and we do it both ways. So here's my rule today. Every tooth that will receive a restoration at the completion of orthodontics will receive a composite restoration to restore ideal anatomy either before or during orthodontics. So what that means is if we're going to be doing 6 or 8 porcelain veneers on the maxillary anterior teeth, at some point, all 6 or 8 of those teeth are going to receive composite. If we're doing a full mouth rehab, and we're going to be putting restorations on 28 teeth at the end of ortho, then either before or during ortho, that patient is going to receive 28 composite restorations to direct the orthodontist to exactly where we want the teeth to be. In my practice today, I primarily do the anterior teeth with direct bonding, as I showed you, and I primarily do posterior teeth with indirect. So we have indirect restorations milled in the laboratory and bonded on singly. They can't be a unit. It has to be done tooth by tooth because obviously we're going to be moving teeth independently with ortho. So I know what some of you guys are thinking. Your BS meter is going off and you're thinking, you know, he's just showing us one case that he did or 2 cases that he did, but this is a lot of extra work and I don't really believe he does this. Well, I have 2 partners in my practice, and one's a young prosthodontist and the other is a very good restorative dentist. And this is the way we all do this in our practice. So this is not just one and out. Every patient that is going to get restorative dentistry done at the end of ortho is going to get composite bonding on every teeth that will be restored either before or during the ortho appliances go on. And the reason we're so adamant about this is because it makes the ortho completely predictable. Because if I make the teeth anatomically correct, then the orthodontist, all he or she has to do is to line those teeth up, and that's what they love to do. They love to line up anatomically correct anterior teeth. So one last quick case, and then we'll move on to the second lesson. So here's a young woman. She's 20 years old, and she's got significant issues going on. I hope everybody can look at her face and her eyes and her wear, and look at the matte finish on her anterior teeth. And I hope most everybody is thinking right off of the bat, there's got to be some type of sleep disorder breathing going on. And in fact, there was. But that's a discussion for later this morning. This young woman comes to me from out of state. Now, I don't treat a lot of people from out of state, but she did. So I've got to make hay while the sun shines when she's in town. So once we begin treatment in the morning, I'm going to do my pre-orthodontic bonding. So there she is before and after the bonding's done. We're going to let her have some lunch. And then in the afternoon, I'm going to do the aesthetic crown lengthening to take care of her altered passive eruption. I'm going to be needing to move, or the orthodontist is going to be needing to move that premolar a little more than some of the others. So I'm making a couple of vertical grooves to facilitate this, a surgically facilitated orthodontic treatment. So this was primarily aesthetic crown lengthening for altered passive eruption. But the wrap effect stands for regional acceleratory phenomenon. The wrap effect that we get from doing a surgical procedure is going to make the orthodontic movement much more efficient for the next 2 to 4 months. So I did the crown lengthening in the afternoon. The next morning, she went to the orthodontist and he placed ortho appliances, and then she went home. So here she is into ortho, and I think you can see that we've lengthened her incisal edges some more with composite. We're not stuck with what we did initially. Obviously, we can continue to change the bonding throughout the ortho, because her goal was to have really long anterior teeth. She hated her short teeth, and she kept wanting them longer and longer through the orthodontic process. And so we continued to add composite to try to meet her goal. So the composite is dictating exactly where the teeth need to go, so that when she's debanded, we can remove the composite and do the porcelain restorations. So there she is completed with her long porcelain veneers, which was her dream. And there she is done. So today our lesson is every tooth that's going to get a restoration at the end of ortho is going to get a composite restoration either before or during ortho. So that was lesson number 1. We must communicate with more than words when we're dealing with the orthodontist. Lesson number 2 is sort of the one I think that's the most difficult for me to show you, because the photograph of that implant case that you see on the right is mine, 9-year post-op. And it just doesn't make me feel good to look at that. This one's even worse. This is a 12-year post-op. This is mine also. So lesson 2 is related to implants placed in the anterior maxilla. So let's look at 2 more of my patients and talk about what the possible outcomes are when we place implants in the anterior maxilla. The first possible outcome is success. So we placed an implant in tooth number 8 area, and then I placed a porcelain restoration on it. And I think that baby looks pretty good soon after it was placed. So that's initial success. However, I think that baby's looking pretty good 10 years later also. So one possible outcome of our implant technique is long-term success. However, the other outcome that I've suffered through the years on occasion is failure. So let's look at another of my patients. And this is a patient that we placed implants in some areas I'll show you next when she was 20, and now we're seeing her 15 years later. And the problem with this patient is that she had late growth after we believed that her growth was complete. So on the upper photograph, you can see that we've placed implants in the tooth number 7 and tooth number 11 positions, and there's a pontic cantilevered off of number 11, replacing missing number 10. So that's the way she looked at age 20. This is the way she looks today. And I think the easiest way to evaluate her is to look at the Pontic number 10. And I want you to look at the movement that has occurred due to late growth in this patient over 15 years. And now she is 35, and there is absolutely no reason to assume that this is going to stop right now. So this is a problem that is going to vex this patient for the rest of her life. And when I've gone and done doing dentistry, her maxilla is still going to continue to be growing, and her teeth are going to be moving, and her implants are going to be in the wrong positions in her head. This isn't my case, but this is the end game. This is the worst circumstance that happens after years and years of an implant being ankylosed, if you will, and the rest of the arch continuing to develop. So why does this happen? Well, let's look at a little bit of the literature. And this was a study that Bernard did, and it's not a large study. It was a fairly small number of patients, but I think the point is well made. So what Bernard did in this study is looked at two groups of patients 4 years after implants were placed. The first group, the implants were placed at a very young age. I think we would all agree 18 years is pretty young to be placing implants in the anterior maxilla. They followed those implants for 4 years, and they found in this group that the infraocclusion was anywhere from none to up to over 1.5 millimeters just in 4 years, as adjacent teeth continued to erupt and grow and the implant stayed in the same place. And you would say, yeah, that makes sense because that's too young. Placing implants in 18-year-olds is too young. So let's look at the other group that Bernard looked at. The average age was 43.5 years. And 4 years after the implants were placed, it was exactly the same numbers, or actually a little worse. So the point of Bernard's study is that vertical changes continue in some of our patients throughout life. This is another fairly famous oft-quoted study by Thielander. And what they did, or what she did in this study, is she looked at patients' study cast from age 5 to age 31. And it was very clear in her study that dentoalveolar development continues into adulthood. So for everybody listening to this that's been placing lots of implants, replacing maxillary lateral incisors, I hope this is making you sweat, because it's exactly what it's done for me. The other problem related to placing implants early in young adults is the fact that the tissue thins over time. We have all seen this. And this is an old study that was done by Garber, but I think it's still relevant because we've all seen what Garber showed us. And that is, in this small study of patients removing implants or receiving single tooth implants, 50% of them showed thinning and bluing or graying in the tissue 4 years after implant placement. So this bluing and graying is something that's very difficult to manage in patients, especially in thin biotype patients, and it's something that we're going to have to assume is going to happen somewhere down the line in a percentage of our patients. So what I've done is giving you the dilemma, and that is that when we place implants in the anterior maxilla in a young adult, we run the risk of late growth, and we run the risk of thinning of tissue and graying over the implant. So what's the solution? Well, for me, over the last 5 years, the solution has become a bonded zirconia bridge. And I know many of you listening have dealt with bonded bridges through the years and have had either good, moderate, or poor success. I started doing bonded bridges many years ago with 2 wings and a metal substrate. And they actually worked very well. Commonly what would happen is the wing on the central would debond, we would cut it off, and the canine would be enough. The wing on the canine would be enough to hold the Pontic. And those metal Maryland bridges were very successful, but they were ugly because the metal would cause a graying through the abutment too. So we evolved away from doing it with metal, and we evolved to doing it with a reinforced composite. And those were beautiful, and they almost universally broke. So that wasn't the solution. We then moved to doing it with a lithium disilicate type of restoration. And those worked better, but they still broke. And so I had very little enthusiasm for using a bonded bridge to replace a lateral incisor until we finally had the advent of zirconia and our ability to bond zirconia. So today, this has become my go-to restoration for replacing a missing maxillary lateral incisor. In order for this to work, I'm going to give you 4 criteria that I think are important. The first is we only use one wing. We've known this now for more than a decade. We do not use 2 wings. We only use one wing on the largest abutment, which is commonly going to be the canine. The other issue that I think is associated, important with the fact that there's only one wing, is that we don't want a wing on the central incisor, but we want a small extension. And it is an anti-rotation extension that keeps the pontic from rotating facially. The tooth was not prepared. The central has no preparation. There is no bonding. You are able to floss between the pontic and the central incisor. The only purpose of that little extension is to keep it from rotating facially. The second requirement, in my opinion, is that the abutment must also have anti-rotation. So I'm actually creating a fairly significant groove that gives me only one path of insertion as I insert this one wing bonded bridge. The third requirement is that you must have an excellent dual cured resin cement with MDP in it. MDP is a monomer, a magic monomer that bonds beautifully to zirconia. So I continue to hear from my friends, some of my friends, that they do not believe that you can bond predictably to zirconia. And I would propose to you, my friends, that that idea has already been proven. We can bond predictably to zirconia. Now, is it going to last for 40 years? And the answer is no. It's going to debond somewhere along the way. So I don't know at what point my bridges are going to be debonding. I know that they are down the road. However, all we have to do once it debonds is to clean it up and rebond it again. Since I've been using an MDP containing material, and the one I prefer today is Panavia V5. Since I've been using that material, I've had very little problem with debonding. So the critics say, yes, we know we can bond short term, but what about long term? And I think that is a totally legitimate concern. However, I would throw back at them, what about the long-term concerns with the implant? So if we know that we can get a good bond initially, but that it's somewhere down the road it's probably going to debond, how do we manage that? And that's the fourth part of the requirements. And that is the patient all go away with an Essex retainer. And they're told that this Essex retainer will be helpful if this ever becomes debonded. Because if it debonds on a Saturday night just before your wedding, you can put it in the retainer, you can put the retainer back in, and nobody will know that the bridge is debonded, and you can come back on Monday to me or somebody else and have it rebonded. So these are my requirements for a bonded zirconia bridge. One wing, anti-rotation on the pontic, anti-rotation groove on the abutment, an excellent dual cured resin cement that you understand, and an Essex retainer to protect the patient, knowing at some point this will probably debond. So my lesson learned, I do not place implants in young adults to replace maxillary lateral incisors anymore. And when I say I'm not placing the implants, I'm restoring them. But I do not prescribe this for my patients anymore. And you should ask the question, what does young mean? And young means to me when the bonded bridge is failing so often that the patient is not willing to hassle with it anymore. So as far as I'm concerned, the bonded bridge is a long-term restoration until proven otherwise. And if it continues to debond, it's one of two issues. Either the dentist didn't understand the bonding system and didn't prepare the bonded bridge correctly, or it's occlusion. And clearly, there are some circumstances where the occlusion in function doesn't allow you to place a bonded bridge. And you either have to make a decision to remove a lot of tooth structure on opposing teeth, or you have to put the patient in ortho to make room for the bonded bridge. So my lesson learned is I don't replace lateral incisors as the first choice anymore with an implant. Lesson number 3, lower porcelain veneers. Just to remind you, this is my patient, this is my veneer. This one also. So let's look at this patient. I placed porcelain veneers on the 3 lower incisors with the asterisk. What's our diagnosis? Dentoalveolar extrusion with wear. Everybody can visualize what these teeth look like before. However, instead of doing ortho and moving the teeth, the upper and the lower teeth into the correct positions, I placed porcelain veneers on 3 lower incisors with a dentin substrate. And this is what happened on this patient. You see, number 23 is broken on one day. On a different day, number 24, and ultimately number 25 broke also. So within a period of 5 years, all 3 of these lower veneers that were bonded to a dentin substrate broke. So why does that happen? Well, it turns out that we're not near as good at bonding to dentin as we think we are. And these are some old studies. The top study was an in vitro study. And you can see that the bond strength to dentin in vitro decreased more than 75% in 5 years. However, you're saying, that's not where I live. I don't live in a laboratory. I live in the mouth. So I think Hashimoto's studies is one of the most important that's ever been done related to dentin bonding. So what Hashimoto did is he took a group of children that were going to lose posterior deciduous molars in the next 3 years. And he did class 2 composites in those. And he had 3 groups. The first group was the control group, and the composites were done within 24 hours of being extracted using products I'll show you in a minute. The second group, the posterior composites, class 2 composites, were done in the mouth, and the teeth were lost within 1 to 2 years. When the teeth were lost, they were then taken to the lab. A slice was made through the teeth, put in the instron, and broken off to determine the bond strength in vivo. And the third group was the same, but it was 2 to 3 years out before the specimens were made. And here's what Hashimoto found. The bond strength decreased in vivo in the mouth from 27 to 9 in 3 years. So what that means is in vivo, when we do bonding to dentin, it's in a state of failure from the moment we put it in. If it's surrounded by enamel at the margins, then we've got a much better chance long term. But if it's all dentin, it's failing from the moment we put it in. It's just a matter of how far down the road it is. And you say, yes, but that was done on primary teeth. And primary enamel is different than enamel and permanent teeth. And you're right, it is. However, primary dentin is very similar to dentin and permanent teeth. The other thing you say is this study was done in 2000, so the products aren't any good. Well, I'm sorry, but Scotch Bond Multipurpose is still one of the best of all dentin bonding agents that's ever been discovered or given to us. It's a 4th generation product, and it's still used by many, including me. Now, I don't use it for everything anymore, but I still use Scotch Bond Multipurpose when I'm doing porcelain veneers on enamel. So this is an important study that shows us that our ability to bond to dentin long term is suspect at best. So what does that mean? Veneers bonded to enamel are significantly stronger than veneers bonded to dentin. Everybody would agree with that. However, this is more problematic. Veneers on half enamel and half dentin substrates were no more resistant to catastrophic failure than those placed on all dentin substrates. So what I'm proposing to you is that when we're doing porcelain veneers on a very difficult subset of teeth, which are worn lower incisors, it's problematic to do those restorations on dentin. So what's the solution to this problem? Well, my solution is don't do it. So today, I don't do porcelain veneers bonded to a dentin substrate on lower incisors. For me, that's a never. So what does that leave us? That leaves us with two other options. The second option is to do full crowns. But full crowns are problematic also, especially when we have taller teeth that are fan-shaped as they go to the incisal edge. So this is the case I inherited, so I'm not taking credit for this. A patient was being seen by a dentist in another city who I knew, who was a very good dentist. And this dentist had done an upper reconstruction on her upper arch using implants and a monolithic zirconia restoration. And it was beautifully done. And he had done it against an idealized lower occlusal plane. So she had a lot of teeth remaining on the lower arch. So he prepared those teeth. He placed provisionals, laboratory provisionals on, and then he created the upper arch against the idealized lower arch. Once the upper arch was completed, she moved to San Antonio. So I had the pleasure of welcoming her into my practice. So now I have to remove the lower provisional, make an impression, and make restorations to oppose the upper zirconia. And when I removed the lower provisional, this is what I found. And I think many of us would stand in judgment of these preparations and say, holy cow, these teeth have been mutilated. But I want you to remember, when you have tall lower incisors and they're fan-shaped as they move to the incisal edge, you have to remove a lot of tooth structure to create a situation where you have draw. So yes, we can judge this dentist for doing this to those lower incisors, but to some degree, he had no choice because the teeth, the shape of the teeth, and because they were so tall. So I'm not going to say I never do full crowns on lower incisors. However, I prefer not to, and if I never have to do another full crown on a lower incisor, my life will be complete. So what does that leave us? If we're going to do porcelain veneer restorations on this patient that we see on the right screen, the only way I feel like we can do this predictably is to bond them to enamel. But the problem is that due to her deep overlap, in order to make room for the porcelain veneers, and I think we would all agree, you've got to have at least 0.3 millimeters and better 0.5. And if you remove 0.3 millimeters off the facial surface of those lower incisors, you will be through the enamel and into the dentin. So what do we have? We have lower incisors that have worn and super erupted up to the occlusal plane of the posterior teeth, and yet they're touching the linguals of the uppers. So in order to make room for veneers, I have to remove 2 millimeters off of the top of those lower incisors, and I have to remove 0.3 to 0.5 off the facial surface of those lower incisors, which means these will be dentin bonded rather than enamel bonded, unless I'm willing to do this. And if I'm willing to intrude those 6 lower anterior teeth, which yes, it took a year to do that. If I'm willing to intrude those teeth, now everything has changed. That which was lost due to incisal edge wear becomes my incisal edge reduction for my porcelain veneers. And now, since the lower incisors have been intruded, we no longer have to worry about that tight relationship between the facials of the lower incisors and the linguals of the upper, which means I don't have to remove 0.3 to 0.5 millimeters of tooth. I can dust the facial surfaces off of those lower incisors. And now this gives me the ability to do enamel bonded porcelain veneers. So on the upper screen is after the patient has been debanded. On the lower is after the teeth have been prepped. Those are enamel preps. And the reason I know it's in enamel is because it's shiny. When you photograph enamel, it's shiny when it's dry and dentin is dull. So other than the dentin on the incisal edges, everything else is an enamel substrate. I'm not even going down on root. There's no reason to go down on root unless the patient dictates it. So this is 95% enamel bonded porcelain veneers. The next cool thing about intruding teeth before you restore them is that the lab technician now has room to make them look like natural teeth with a normal pitch and bevel. In the old days, when we used to place porcelain restorations on top of worn lower incisors, this is what we got. We got thick, fat incisal edges because the lab technician had no running room to bring the teeth back up to a normal pitch and bevel in porcelain. But once we intrude the teeth, now the lab technician has the ability to bring the incisal edges back up so that they're anatomically correct and pretty. The last cool thing about intruding teeth before we restore them is that it works. So here's the same patient 23 years later. This is a 23-year post-op on that patient. And I want you to look at the left canine. And I want you to see that wear facet. That is not a chip, it's a wear facet. And this patient wears a night guard every night because if she doesn't, she wakes up with a headache in the morning. So I know she wears her night guard. So when is this parafunction happening on that lower canine? And the answer is it's daytime parafunction. So the point of this is that these porcelain veneers have been functioning for 23 years in this woman's mouth in a very toxic oral environment, and yet they've done beautifully. And it really is not because of anything that I did, it's because they're bonded to an enamel substrate. Remember, these veneers are feldspathic. These aren't Emax veneers because Emax wasn't available 23 years ago. So these veneers are in the range of 3 to 4 times weaker than our current porcelain, and yet they've done beautifully in this toxic environment because they were bonded to an enamel substrate. So my lesson learned on lower veneers: I do not place porcelain veneers on lower incisors with a dentin substrate. I either choose not to treat the patient or send them into ortho, get the teeth in the correct positions, or ultimately move to full coverage. So that's my third lesson learned. My fourth lesson learned is related to an area of my practice that I've always enjoyed doing, and that is aesthetic crown lengthening. Now, I don't do a lot of things in my practice. I don't place implants. I don't treat kids. I don't do endo. But I've always done my own crown lengthening. And so I'm going to talk to you about my experience of doing aesthetic crown lengthening for 30 years, because I did my first case back in about 1990. And most of the time when I did aesthetic crown lengthening, it would be stable long-term. But occasionally I would do aesthetic crown lengthening on a patient, and in a matter of a year or 2 or 3 years, the tissue would grow back where it was before. The vexing problem of gingival rebound. And it was a problem that really bothered me for years. And I observed what I was doing, and I was trying to figure out why I got this occasional rebound. And over the years, I finally believe I've come to understand why it occurs. And I would propose to you that there are 3 reasons that you can get gingival rebound after aesthetic crown lengthening. The first is inadequate ostectomy. So this is a case that I'm going to be doing a lot of dentistry on, but we're going to be doing aesthetic crown lengthening to start with. And one of the areas that I've come to realize is a danger zone when I do aesthetic crown lengthening is the mesial of the lateral incisors. Because if we don't extend the ostectomy more interproximally, when we're doing it on the mesial of the maxillary lateral incisors, we tend to end up with a very triangular shaped gingival crest at the end. So what I'm proposing to you on the photograph that you see is that there is inadequate ostectomy on the mesial of the upper right and upper left lateral incisor. I think it looks good on the centrals, but on the laterals, the ostectomy needs to extend farther interproximally so that we don't end up with a very triangular shaped gingival crest. So there's the patient post-op after she healed. And there she is after the dentistry's been done. And I think we would all agree that the gingival crest, the zenith on number 7 and 10, the upper left and right lateral incisors, is not ideal. It's too triangular shaped. And the reason it healed that way is because my ostectomy was inadequate on the mesials of number 7 and 10. So the first reason you can get rebound is when you don't do the ostectomy correctly. This is a case that I think I did better. So look at the contours of number 7 and 10 right now. She obviously has altered passive eruption. We elevated a flap, and I did more ostectomy. I brought the ostectomy farther in on the mesials of the lateral incisors, there and there. And she's now healed with a much more aesthetic gingival zenith than we saw in the last patient. So when you're doing this procedure, or if you're referring it out, if you find that you don't like the gingival zenith on any tooth, but especially on the maxillary lateral incisors, it is a function of an inadequate ostectomy. The second lesson I learned through the years when I was looking at my rebound is one that I can't control, and that is bone regrowth. And when I talk about the bone regrowing, it is not going to regrow vertically. If you move the bone 2 millimeters apical to the CEJ from line angle to line angle, it is not growing back vertically. That's my experience and belief. However, it can grow back in terms of its thickness. So let's look at that. This is Adrienne. Adrienne is the daughter of my office manager. And my office manager has seen through the years all the aesthetic crown lengthenings we've done. And she couldn't wait for Adrienne to come in when she turned 16 to get her free crown lengthening done as a member of the family. Everybody knows how that goes. So it's an easy diagnosis to make. Adrienne's got short teeth and a gummy smile. We measure her central. It's 8.5 millimeters long. We feel for the CEJ and the sulcus. We cannot feel it. So that's how we make a diagnosis of altered passive eruption. The tooth is short by measurement, and we cannot feel the CEJ in the sulcus. These are my goals when I do aesthetic crown lengthening. And I'm going to assume that these are fairly similar to your surgeon if you're not doing it yourself. When a flap is elevated, the bone is always too close to the CEJ in some areas, and it's almost always too thick. So my goal is to thin the bone and move it 2 millimeters apical to the CEJ from facial line angle to facial line angle. This is only a buccal flap. Interproximal bone and soft tissue are left intact. Palatal tissue is left intact. It's a thinning incision over the papillas. How far back does the incision go? It goes one tooth distal to the distal extent of the smile. And the distal extent of the smile is generally the mesial of the first molars. And so routinely my incision goes from mesial to second molar of one to the other. It's a giant mistake to stop the surgery in the premolar regions because it commonly results in a step down gingivally in the posterior part of the mouth. Once I've moved the bone into its correct position, 2 millimeters apical to the CEJ, I place the gingival crest 3 millimeters coronal to the new alveolar bone position, which means the CEJ will be a full millimeter subgingival at the end, and then I suture at that new position. So here's Adrienne pre-ostectomy. And what I want you to notice when you look at her pre-ostectomy, the bone is close on the canine. It's close on the lateral. It's farther away on the central. It's closer on the lateral. Farther away on the lateral. And it's closer on the canine. So this is what I always find. The bone is not uniform when we elevate a flap in a patient that's got altered passive eruption. It is in different positions on individual teeth, and it has different amounts of thickness. So this is after the ostectomy. So what we've done is we've festooned in between the roots, and we've moved the bone 2 millimeters apical to the CEJ from line angle to line angle and thin that bone down. We're now going to coronally position that tissue, the flap, and suture it with simple individual sutures using an English surgeon's knot and 5/0 vicryl suture. So here she is immediately post-op. Obviously, we're going to clean up that heme before we send her home. But what I want you to notice is that the sutures are white. 5/0 vicryl is a white suture. It takes the color of heme and it becomes essentially invisible. We do not place a periopack because there's nothing to hold a periopack in place. The patient goes home with instructions to not brush their entire mouth for 4 days. And we give them an antimicrobial rinse to use twice a day. On day 5, they can start brushing their lower arch. I don't want them to brush their upper arch for 2 weeks. We get them back for suture removal in 5 to 7 days, and they continue with the antimicrobial rinse up to 2 weeks. The post-op course is very easy on these patients. There's never a need for a narcotic. This is always managed with ibuprofen, generally only for 1 or 2 days post-op. These patients should heal up very quickly. So here's Adrian at 6 weeks. And at 6 weeks, there's no indication that we've done anything surgically. The CEJs are still a full millimeter subgingival, but now we have the actual length of the clinical crown in the mouth. You'll notice there's a black triangle there. The reason there's a black triangle is because there was a black triangle pre-op. And in fact, I'll just show that to you. You can see in the upper screen that there's a black triangle pre-op. The reason you can't see it there is because it's filled in with plaque. So the point is we do not create black triangles when we do aesthetic crown lengthening procedures. My goal, my view of success once I've done an aesthetic crown lengthening procedure is I want there to be no scars at 6 to 8 weeks. I want the tissue to be level at its new position, and I want the tissue to have grown back with a knife edge. If the tissue grows back with a rolled gingival margin, then there's commonly some type of surgical error. So again, I want no scars. I want tissue essentially healthy at 6 to 8 weeks with a knife edge, as we see in this patient. So here she is at 6 weeks post-op. And there she is, done. And Adrian at this point was 16 years old and very happy with the result. However, over time, she came back with a complaint that she was having more gingival display, especially in the posterior. She had some rebound again. So this is one of those patients that I believe rebounded because of lateral bone growth, and I'm going to prove that to you. So this was the initial ostectomy I did in 2009. And I want you to look at pre-ostectomy when I flapped it again in 2016. And I think you can see that the bone has not grown vertically back towards the CEJs, but the bone has gotten thick. And it's gotten thick in the front, and it's even gotten thicker in the back. So you'll notice the bone thickness over the 2 central incisors. You'll also notice on tooth number 7, the upper right lateral incisor, that the bone appears to have grown back towards the center of the tooth. So it doesn't grow vertically, but it does thicken out, even more so in the posterior. So that was the ostectomy after it was completed on the top screen in 2009. And look how much it has regrown in those 7 years. And we've all experienced this. I mean, we've taken off tori and had them grow back, and exostoses and had them grow back. Well, that's exactly what's happened here. And the problem is, it's when the bone gets thicker, it causes the tissue to move coronally on the teeth. And that's the etiology of the rebound. And this is not something we can predict, nor can we do anything about to keep it from happening. The only thing we can do is to go back and do the ostectomy again. Here's the other side. The flap's in the way a little bit because I wasn't trying to prove anything in 2009 because I didn't know the bone was going to grow back. But I think you can really see in 2016 how the bone has grown back with a vengeance. You can see that it didn't go coronally, it just grew buccally, which caused the tissue to migrate coronally. So this is before and after, and it's helped a little, but it didn't help a lot. So the reality is that if Adrienne wants to have less gingival display in the posterior without exposing roots, which I'm not going to do, I'm not going to expose her roots surgically for aesthetics if I don't have a reason for covering them up. So the answer for her is two things. Either she can get Botox to decrease the lip mobility, or she can have orthodontics to intrude her posterior teeth, which would be the better solution. So the second reason that people have gingival rebound is due to lateral growth of the bone. The third, and I think perhaps the most interesting and the hardest one for me to figure out, was the type of biologic width that the patient presented with. So let's have just a little dive into the pool of biologic width. The biologic width numbers were given to us back 59 years ago by Gargiulo. This is one of the most quoted papers of all time in dentistry. And what Gargiulo told us is that the biologic width is approximately 2 millimeters, approximately 1 millimeter of epithelium and approximately 1 millimeter of sulcus. So I suffered with that information for many years because my patients didn't know the rules of biologic width. They didn't know that it was supposed to be 2 millimeters. And so I would have some patients that would have rebound. I would have some patients that had recession. I would have some patients that would have inflammation long-term around my crowns, and yet I treated them all the same. And I didn't understand the issue of biologic width until I had the great fortune of hearing Dr. John Coy speak for the first time in 1995. And the day I heard him speak, I'd never heard of him before. The day I heard him speak, he was talking about biologic width because he had just started publishing that data the year before. And Dr. Coy explained biologic width to me for the first time where I could really understand it. I'll be forever grateful to him for that. And what Dr. Coy said is that there is not one type of biologic width, there's actually three. And he termed them normal crest, high crest, and low crest. So in order to understand this rebound issue, we have to understand the three categories of biologic width. And in order to determine whether a patient is high crest, low crest, or normal crest, you have to bone sound. So what that means is you have to anesthetize the patient, you have to take a periodontal probe, and you have to push it up through the attachment apparatus until you engage alveolar bone. And once you do that, you will have a distance or a number from bone to gingival crest. And based on that distance, Coy suggested that there are three different types of biologic width. The first he called normal crest. There's nothing intuitive about this. You just have to memorize it. Normal crest means that when you bone sound mid-facial, maxillary anterior tooth, from gingival crest to alveolar crest is exactly 3 millimeters. It's not 2.5, it's not 3.5, it's exactly 3 millimeters. And when you bone sound interproximally, from tip of papilla to crest of alveolar bone is a range, anywhere from 3 to 4.5 millimeters, depending on how highly scalloped the tissue is. So those are the defined numbers for normal crest. This is the way it looks. Patient's anesthetized. You take your perio probe, you push it up until you engage alveolar bone, and from gingival crest to alveolar crest is 3 millimeters. So what does this mean to me? Well, the good news is that most of our patients are normal crest. And what it means is that essentially they are the normal patient that we work on. They have about 2 millimeters attachment and about 1 millimeter of sulcus, and we can place an intragravicular margin and it will do well long term, because our goal is to never place the margin of a crown closer than 2.5 millimeters to bone. So this is the good news. The good news is that most of the patients you treat are normal crest. The bad news is that 15% aren't. So the second group that Coy's talked about is high crest. And high crest means that the gingival crest is less than 3 millimeters to the alveolar crest. So mid-facial, it's less than 3 millimeters from gingival crest to alveolar crest when you bone sound, And interproximally, it's less than 3 millimeters from tip of papilla to alveolar crest when you bone sound. And here it is. And there's no way to know this patient is high crest until you bone sound. You can't tell by looking. So what does it mean to me? It means that the tissue is very stable. You never have to worry about recession in the high crest patient. The problem is that if you place an intraclavicular margin in a high crest patient, you will very likely create a biologic width impingement because your margin will be too close to bone, and that will result in long-term inflammation. The good news, it only occurs 2% of the time. So this is not something that we have to deal with very often. But if you have a patient that needs a crown on a maxillary anterior tooth, and that tooth is dark, let's say, and you need to go subgingivally with the margin of your crown to cover the darkness, and they are high crest, you're in trouble. And the only way you know you're in trouble is to bone sound before you ever put a burr on that tooth. The third group, which is the most difficult for us as restorative dentists to deal with, is the low crest patient. And by definition, that means that when you bone sound, mid-facial, from gingival crest to alveolar crest is greater than 3 millimeters. It could be 4, it could be 5. And when you bone sound interproximally from tip of papilla to alveolar bone is greater than 4.5 millimeters. Here it is. Once again, you can't tell this patient is low crest unless you bone sound. It is impossible to know any other way. So what does this mean to me? What this means is that this patient is predictably going to get recession. This is what Dr. Coys has taught us. If you bone sound a maxillary anterior tooth and it is 4 or 5 millimeters from gingival crest to alveolar crest, when you pack cord and place a crown, you're very likely going to get recession over time. So now you understand the 3 different crest positions that Coys described. However, I'm now going off script with Dr. Coys because I believe there's a problem with the low crest concept. It's more complicated than that. And here's what I think the problem is. Patient A, we bone sound. From gingival crest to alveolar crest is 5 millimeters. What do we call that patient? By definition, that patient is low crest. Let's look at patient B. We bone sound. From gingival crest to alveolar crest is 5 millimeters. What do we call that patient? Low crest. So if all you're going by is bone sounding, then both of these patients are low crest and they're going to act the same when we do dentistry on them. And in my opinion, that's absolutely wrong. Patient A is very different than patient B, and they're low crest for different reasons. So back in 2007, when I finally figured this out for myself, I wrote an article. I'm going to show you that next. And I termed 2 types of low crest patients, unstable and stable. So let's talk about unstable first. This is a patient that's got the normal 2 millimeter attachment apparatus, but they've got a 3 millimeter sulcus. And I want you to think about the gingival tissue as a cantilever that's attached on one end. So you have a 3 millimeter cantilever of gingiva that's attached only at the base of the sulcus. And nature cannot predictably maintain a 3 millimeter cantilever. And this is the patient that you get recession on when you pack cord. That's the reason I call this patient unstable low crest. However, the stable low crest is different. They've got a normal sulcus and they have a biologic requirement for a longer attachment apparatus. And this patient, you can treat like normal crest. You don't have to worry about getting gingival recession in the stable low crest patient. Now, I know I've gone over this really fast, and I know this is confusing. So this is the article I wrote back in 2007, and it has everything along with the diagrams that I just showed you that you're welcome to look at. The article or the journal is no longer available, and so you can't find it. Generally, it's hard to find. So if you want it, you can just go to my website, and on my website, there's an icon that says teachings. And when you hit teachings, You will then see recently published articles, and this will be there for your download. So if you want to pursue a little bit more of my ideas about biologic width, that would be the best way to do it. So now we have two types of low crest to deal with. We've got unstable and stable. So here's the bottom line. In the unstable low crest, it's the patient with the deeper sulcus. If you do dentistry on them, you expect to get recession over time. So the unstable low crest is bad for the restorative dentist, but it's good for the surgeon because we can treat this patient like a normal surgical patient and we will not get gingival rebound. Okay, that's the unstable patient. This is the stable low crest that's got the normal sulcus and the requirement for more than the 2 millimeters of attachment apparatus. So in this patient, it's bad for the surgeon because if the surgeon doesn't realize this is a stable low crest patient, they will only make room for 2 millimeters of biologic width when they need to make room for 3, which means the surgeon must remove an extra millimeter of bone when doing crown lengthening on a stable low crest patient. But it's good for the restorative dentist because we don't have to worry about recession. So let's look at two patients. 2005 was just about the time I figured this out. It was soon after I'd heard COIs and I started trying to figure out why I was getting the occasional rebound after I did aesthetic crown lengthening. So here's a young woman that has small teeth for all 3 reasons that they can present with a little tooth. The first is microdontia, she's got it. The second is incisal edge wear, she's got it. And the third is altered passive eruption. She's got all 3. So she has a 5 millimeter long central. She's got Maryland bridges that are failing, replacing her maxillary lateral incisors. So I'm first of all going to do aesthetic crown lengthening. And I'm moving the bone 2 millimeters apical to the CEJ from line angle to line angle, as I've already described. So you can see the post-ostectomy on the lower screen. I'm now replacing the tissue so that it's 3 millimeters coronal to the bone. So at 6 weeks post-op, we went from 5 to 7 millimeters. That's a good result. The CJ is still a millimeter subgingival, and yet we've got significantly greater length on this tooth. However, we don't have the ability to lengthen her front teeth because she's end to end. So we're now going to send her to ortho to realign the teeth so that I can do restorative dentistry on her. So there she is after the teeth have been moved into a position to allow me to do the restorative dentistry. But the problem is that I got a millimeter of rebound after the surgery. She went from 7 back to 6. And you say, well, just 1 millimeter is no big deal. It's a big deal when the tooth is only 6 millimeters long. That's 15%. So it was a very disappointing result for my aesthetic crown lengthening. So in order to figure it out, I finally realized that every time I had a rebound after my aesthetic crown lengthening, it was always a low crest patient. You can see when I'm bone sounding now, it's 5 millimeters from gingival crest to alveolar crest. However, when I did a very gentle sulcus probing on this patient, it was 2 millimeters. You have to be very gentle in your sulcus probing. So if we have a total of 5 millimeters from gingival crest to alveolar crest, and we've got a 2 millimeter sulcus, that means we have an attachment requirement of 3 millimeters. However, I only created an attachment requirement or a place for the attachment of 2 millimeters when I moved the bone 2 millimeters apical to the CEJ. And that's the reason we got a millimeter of rebound. So what would we call this patient? Is this patient low crest stable or unstable? And the answer is this patient is low crest stable because she has a biologic requirement for a longer attachment apparatus than most human beings. So how do we manage this? We go in and do the surgery again for free because I didn't know it needed to be done correctly the first time. I didn't know the first time I needed to remove an extra millimeter of bone. So the first time I removed 2 millimeters, the second time I removed another millimeter to give me now 3 millimeters from alveolar crest to CEJ. Now I've got room for her longer biologic width. So we went from 6 millimeters back to 7 millimeters, and the tissue has remained stable. Now, I'm not here to talk about the implant failure that you're going to see. Back in these days, we didn't have narrow implants that we could remove the abutment from. So those were Nobel direct implants with the abutment as part of the implant. And there still wasn't enough room for the implant. And we know when you put an implant in and there's not enough room, we tend to lose interproximal tissue. So you can see that we've lost interproximal tissue between the implant and the centrals on both sides. But that's not the lesson. The lesson in this case is that for the next 10 years or 11 years, this tissue has been very stable at that position. Even though if you bone sound her, she bone sounds low crest. So this patient is a low crest stable patient that required a greater ostectomy to make room for her greater length of biologic width requirement. Okay, so let's look at one more patient that's more current. So this is a low crest stable patient that I diagnosed correctly. So we're going to do aesthetic crown lengthening on her. She's canted down from right to left. We bone sound her, and when we bone sound her, she's 5 millimeters. So what does that mean? She's low crest. However, when I go back and do a very gentle sulcus probing, it's 2 millimeters. So that tells me that she has an attachment requirement of 3 millimeters, which means I've got to do an extra millimeter of ostectomy. So I'm not doing 2 millimeters from CEJ to bone. On this patient, I'm going 3 millimeters from CEJ to bone. So here is after my ostectomy. Notice the bone has been scalloped interproximally, festooned. The bone over the teeth been thinned very nicely, and it's now 3 millimeters from CEJ to bone, not the traditional 2 millimeters. I suture the tissue back into its correct position, and she heals. 3.5 months later, we do the bonding in the morning, the pre-orthodontic bonding, and in the afternoon, she went to the orthodontist and he placed appliances and tads to level her with horizon. 12 months later, she's been level with horizon. Posterior occlusal relationship is good. We deband her and do our porcelain restorations from second premolar to second premolar. She's now 3 years post-op and her tissue is very stable. Even though she's low crest, I have no assumption we will be seeing recession over time. She needed the extra millimeter for her extra requirement of biologic width. So this is a low crest, stable patient. And there she is 3 years post-op with the tissue stable in its new position. All right, so the fourth lesson learned took 30 years to figure out. The first reason for rebound is inadequate ostectomy. The second is bone growth, the thickness of the bone regrowth, which we can't control. And the third is the low crest stable patient, which we can control. Because if we diagnose it before we do the surgery, then we know we need the extra millimeter of ostectomy. Okay, my friends, we're down to lesson number 5, which is the last one. And this is an airway lesson that you're going to see has been a very painful lesson for me to learn. So I'm going to share with you a patient that I did back in the mid-2000s. And this patient had significant wear on his posterior teeth and a ton of wear on his anterior teeth. So we're going to do a full mouth rehabilitation on this patient. But first of all, we're going to do what we've been doing for years, and that's to improve the situation by orthodontically moving teeth into the correct positions before we do the restorative dentistry. So he is now in the ortho, lower incisors are being intruded, and there he is complete. So again, it's not the most beautiful case for sure, but he had a low lip line, and the fact that number 10 is higher gingivally really he didn't care about that. So it's a mediocre aesthetic outcome for sure. So here he is before and after, and I want you to notice that not too long after I finished the case, it started breaking. And unfortunately, I didn't take a bunch of photographs of the crowns as they broke, but there's the first one. That's the first one that started to break. and eventually they started breaking on both sides. So here's the patient when I finished him in 2006, and then he died in 2008 at age 64. And this gentleman took great pride in his health. He was proud of the fact that he could do 100 push-ups every day. But unfortunately, he had an underlying cardiac problem that resulted in his death 2 years after I finished his full mouth rehab. And I know, looking back at him today, that there was something else going on with him, but I didn't know it in 2008. And I'll always regret that on this patient. So let's move to 2010. I'm now starting to have my consciousness raised that airway is something we've got to pay attention to. So let me introduce you to Oscar. He's 39 years old. He's young and healthy. He's an athlete also. Lives part-time in San Antonio, part-time in Mexico. He's married happily with 3 children. He's a healthy guy, except that he snores. He's had sporadic dental care, a couple of restorations. He's aware that he grinds his teeth, but he's never worn an oral appliance. His chief complaints: my front teeth are getting shorter and I'm concerned about continuing wear. I don't like my smile as my front teeth are getting shorter. So these were Oscar's goals: stop the wear of my teeth, improve my smile, and use a conservative approach. So he's got less than 100% of incisal display, even in full smile. That's as high as Oscar can get, even when he goes into a high E position. He's got no incisal display in repose, and in fact, his incisors are -2 up underneath the lip. So this is a hard place to start on a 39-year-old man. Doesn't have enough space. He's got crowding. And he's got minimal incisal display with a significant amount of wear in the front and in the molars. So that's the front teeth with horizontal wear. And that's the molars. And they look the same on both sides. The first and second molars on both sides had significant attrition and erosion. That's the other side. Erosion and attrition down to the gingival crest. All right, so for those of you who know me, know that my cases always start with the 4 global diagnoses and the 5 questions that lead me through the diagnosis. So these are the 5 questions that we must ask to make a global diagnosis on a patient. The face height should be 1-to-1, middle and lower third. The upper lip should be in the range of 20 to 24 millimeters long, and the lip mobility from repose to full smile should be 6 to 8 millimeters. The gingival line should be straight or parallel to horizon. The maxillary central incisor, 10 to 11 millimeters long, and we should be able to feel the CEJ and the sulcus. So this is the normal patient. These are the answers to the 5 core questions on Oscar. Mid-face 65, lower face 71. 22 millimeter lip, 6 millimeter mobility. Concave gingival line, 7 millimeter long central, and I cannot feel the CEJ and the sulcus. So let's do a global diagnosis on Oscar. We can get rid of the lip length and mobility because that's normal. So that leaves us with 3 possibilities. When a patient has a long lower third of the face, what we think of is vertical maxillary excess. The maxilla has grown vertically too long. He does not have vertical maxillary excess. He doesn't even show gingiva. So even though the lower third of his face is long, it's because he's got a big mandible, not because he's got a long maxilla. So Oscar does not have vertical maxillary excess. Does he have dentoalveolar extrusion with wear? Yes, he does, because he's got the curved gingival line. Those are supposed to be straight, and yet they're both concave. Does he have altered passive eruption? His tooth is 7 millimeters long, and I can't feel the CEJ and the sulcus. The answer is yes. He does have altered passive eruption. But does it matter? And the answer is no, it doesn't matter, because you can't see the gingival margins in his full smile. So essentially, the only thing I have to worry about on Oscar is dentoalveolar extrusion with wear. So these are the regional diagnoses that go along with it. The global diagnosis tells us where the teeth and gingiva go in the patient's face. The regional data are all those that we've traditionally gathered. That would be caries and periodontal disease and crowding and all of those issues. So those are the regional diagnoses I must pay attention to. So here's my treatment plan. It goes down what everybody would do until we get down to number 4. So the lower molars are very short, so we're going to do functional crown lengthening on the lower molars. We're going to do bonding. Now today it would be pre-orthodontic bonding. Back then it was intermediate. We did it halfway through. We're going to increase his VDO with composite on the molars. We're going to intrude and flare his upper anterior and lower anterior teeth. We're going to align the teeth, and then we're going to do veneers on 6 through 11, the upper anterior 6, and we're going to do crowns on the 4 lower molars. You'll notice referral to sleep physician is not highlighted because I wasn't doing that in 2010. Unfortunately, that came at the end rather than the beginning. All right, so as we start treatment, patient goes into ortho appliances and the ortho's begun. I'm now going to open his vertical dimension using a leaf gauge by adding composite to the lower molars. And I'm just opening his vertical dimension enough to give me room to do the bonding on the anterior teeth. So using a leaf gauge, I just arbitrarily increase his vertical dimension by adding composite to his 4 molars. At this point, he is now only hitting on the 4 molars. I now can go in and do my intermediate bonding. So that's where he started. That's where he is once we've increased the vertical dimension with the composite. And there he is after the intermediate bonding. Now the orthodontist knows exactly what to do. He has to flare the upper anterior teeth to be able to bring the lower anterior teeth forward. And once he gets the lower anterior teeth in the correct aligned positions, he can then bring the upper anterior teeth back into occlusion with the lowers. And then all he has to do is to extrude the premolars on the upper right and upper left, and the case will be done. So there's Oscar at the end of ortho. It took 19 months, and you can see the composite has directed the teeth into exactly the right position. So this is the most powerful photograph. Before we started on the upper and after I removed the bonding on the lower the day I'm ready to prepare his teeth. So the bonding dictated the positions of those teeth so they're in exactly the correct position so I can go in and do my enamel bonded porcelain veneers with a good horizontal overlap and vertical overlap coupled at a good interincisal angle and a good AP occlusal plane. So there he is before and there he is after. We went from 7 millimeters to 10 millimeters. And there he is 8 years post-op. Still functioning well with his retention on the lower, before and after, and done. The other cool part about this is, if you remember, I added composite to the 4 lower molars. I didn't need to restore the upper molars, just the lowers. So when I increased his vertical dimension by adding composite to the lower molars, that became his new vertical dimension. And at the end of the restorative dentistry then, I could take the composite off of the tops of those lower molars, and that became the occlusal reduction for my restorations. So it allowed me to be more conservative in the front and in the back of the mouth. So what's the last step? Well, back in 2011 or 12, the last step for me, because my consciousness was just being raised to it, was doing a sleep study. I didn't know to do it before, but fortunately I knew to do it after. So Oscar's, although he's a 39-year-old healthy young man, athlete, he had moderate obstructive sleep apnea. And it's only going to get worse as he ages. So the good news on Oscar is that he's 10 years out and he still lives because we started to incorporate the concept of sleep disordered breathing into our practice. So let me finish with a current case and we'll be done. This is a patient that is almost completed, not quite, and it's been done by my partner, Dr. Brad Beckel. So this isn't my case, this is Brad's case. So we look at this young woman and we can see that she's got a significantly constricted maxillary arch. She's got a significant transverse discrepancy. So there we see her upper and lower arches pre-op. So our goal, or Brad's goal in treating this patient, was to expand her upper arch significantly to jump her out of crossbite. So he started using SFOT, surgically facilitated orthodontic treatment, with the idea that he was going to try to get as much expansion as he could get with that. And it was a really good expansion. You can see the upper is before, the lower is after, and you can see that they gained quite a bit in intermolar width of the palate, but it still wasn't enough to jump her posterior teeth into a normal bite out of crossbite. So this is where the next step occurred. And this is something we've incorporated into our practice over about the last 2.5 years that's made a giant difference in our patients. It's called mini implant assisted rapid palatal expansion. In the old days, we could only predictably do palatal expansion on kids up to about age 13. After that, we could no longer predictably expand their maxillas with tooth-borne appliances. However, today, instead of using tooth-borne appliances, we're using implant-borne appliances. So that appliance has 4 holes where 4 mini implants are going to go into the palate with bicortical fixation. The 2 arms you see going on to the molars are not active. They are just trying to keep the MARPI appliance from pushing one way more than the other. So all of the expansion is going to be based on skeletal expansion. It's not going to be teeth expansion. Dr. Juan Moon is the one that described this early on, and he's the one that gets a lot of credit for this. So you can see he first started writing about it in 2015. So this is still a fairly new concept. So this was the day the MARPI appliance was placed in the patient that we're looking at. And the goal was to get a greater amount of skeletal expansion in the palate. There are the 4 mini implants that have bicortical placement, meaning that they're going to be stable throughout this whole movement. At least that's the goal. We'll talk about failures in a moment. And you can see how much more space there is between those 2 mini implants 14 days later than when they started. And that's the palatal expansion that's occurring. This is the protocol that we use depending on the appliance that's used. So essentially it's going to be 1 millimeter of expansion per day until the raphe breaks open. Once it wraps open, not in all patients, but in most patients, a space will be created between the centrals, which you can see here now. Obviously the arch wire can't be connected at this point. Now, once it's cracked open, the patient can go in and open this up very easily with very little discomfort associated with it and expand the palate significantly. So there she is, 17 months into treatment time. You can see how much better her posterior overlap situation is 17 months later. I'll show you a better shot in a moment, but this is the powerful photograph. This is the before and after the MARPI. The other thing I want you to see is the before and after. You can see on the right side, if you look in the palate, you can see where the expansion occurred. So the appliance must remain, after the expansion is complete, the appliance must remain in the patient as a stabilizer from anywhere from 3 to 6 months. My orthodontist, Dr. Tito Norris, that does this for me, generally only stabilizes these patients about 3 months after the final opening of the suture. The other cool thing about this, notice that this woman has a significant deviated septum. That hasn't been fixed. But also notice her airway. Her airway has a significant greater flow post-MARPI than it did pre-MARPI. And almost 100% of the patients that we've done MARPI on say this. From the moment it popped open in my palate, from the moment the raphe popped open, I took a breath and I've never breathed so well in my life. So when you get palatal expansion with SFOT, you're just getting palatal expansion, and it's a good thing. But when you get palatal expansion with MARPI, you're not only increasing the palatal inner arch width, but you're also increasing the airway, a giant advantage for our airway patients. So this is the patient before and after, and I want you to look at the posterior teeth. I want you to look at the amount of crossbite she had before, and I want you to look at the normal horizontal and vertical overlap after the ortho. And this was done in less than 2 years. This is the coolest part. Her intermolar width pre-op was 27 millimeters. Post-MARPI, it was 37. And the goal would be at least 35. So if you measure a patient with a 27 millimeter distance between molars, they absolutely have a constricted maxillary arch. So here's the patient. Brad's almost finished with her. This is just provisional. You can see there's still a little bit of cant left, and he's working his way through that. But the cool part today is that we've gone through an evolution, and I showed you what my evolution was back from the early 2000s to right now. And my good friend Jeff Rouse, that teaches a lot of airway information to me, he said we have had 3 stages in our treating of our patients. The first was ignorance of airway. We then went to airway aware, and now the airway is actually impacting our treatment plan from the start. This is the clinical data from the MARPI cases that my orthodontist, Dr. Norris, has done. He's done more than this now. This data is about 3 years old, but he's delivered 56 of these appliances, 8 to 60 years. He's had only 3 failures, but those 3 failures were all in adults, and they're all in adult males. So what we're coming to realize, and it's what's in the literature, this works really great for teenagers and young adults. It works well for women, even as they get into their middle ages. It doesn't work so well for men. So what happens if you want this with a man? You want a palatal expansion. Traditionally, there was only one way to get it, and that was with SARPI, surgically accelerated rapid palatal expansion. And that's where the oral surgeon would go in and make 5 cuts in the maxilla, and then a palatal expansion could be done. Okay? But today, there's a new procedure called a dome procedure that's been made famous by a guy named Stanley Liu, who is an ENT doctor in the Stanford group. And instead of having to make 5 cuts, he believes that commonly you can get away with only 2 cuts. So if you have an adult, and especially a man, and you can't get the expansion with the MARPI appliance, then you can have a dome procedure done in an outpatient procedure. So here it is. So the surgeon's taking a piezo device, and making a cut at the buttress between the zygoma and the maxilla. So he's going to make a cut on the right and a cut on the left, and therefore doesn't have to go back and make cut in the pterygoid region. Sometimes he also has to make a cut here. He makes a break at the midline. They don't always do that, but they do that sometimes. So this is what the cuts look like for the dome procedure. Instead of doing a true orthodontic surgery, it's just 2 cuts made at the junction between the maxilla and the zygoma on the right and left. Now this will pop right open with the MARPI appliance. So here's the lesson learned for me from 2008 to 2020. If you have a patient that presents with attrition, erosion, then there's a very high probability that they're going to have sleep disordered breathing, because those 3 things go together like 3 evil triplets. And Jeff published his first article about this, which he called the bruxism triad, back in 2010, which was the time when it started being raised in my consciousness. So we are no longer just airway aware. It is now dictating our treatment plans, and it's essentially the first thing we look at when we're doing sophisticated dentistry on our patients. So what I've done with you over the last hour and a half is I've shared with you my evolution and my journey. And my journey has been punctuated by some failures, for sure, but I've learned along the way from the failures. And thanks to my mentors, among them Dr. Jim Summit, for helping me to realize that failures are not something to be ashamed of. They're something to learn from. So this is who I am, and this is how you can get in touch with me. And one last thing. Recently, one of my best buddies, Jim Otten, and I decided to create an online study club. And we've just launched it. And if anybody has any interest in learning about being a member of our online study club, then please just email me at that email address, robbinsdds@aol.com, and I'll tell you more about it. So Tim, thanks so much for the opportunity of allowing me to be here with you today. It's been a great pleasure.
Oh, thank
everybody,
you.
good luck on their reentry back into their practices.
Thank you, Dr. Robbins. Do you have a few minutes? You can answer a few questions for us?
Absolutely, I do.
Okay. We've got a little bit of time here because our next speaker, Dr. Neil Grassetto, isn't coming online until 11:40 with us. So back to bonding, pre-ortho bonding. How do you account for rotated teeth or for wear at the incisal plane?
Okay, so great answer. If the teeth are rotated or crowded so much that I can't do the bonding, then that's when we do intermediate bonding. So that's the one time today that we tend to do intermediate rather than pre-orthodontic bonding, and that's when we got a great deal of rotation. The idea about cants, I don't worry about a cant. I'm going to lengthen the teeth and just make them the correct length, but I'm not going to correct the cant in the bonding. That then the canted teeth then dictate to the orthodontist how he or she is going to intrude and how much to intrude to get them lined up. So the one place today we do intermediate orthodontic bonding is when there's so much crowding that we can't do a good job.
Okay, thank you. Is vertical maxillary excess the only time you don't do pre-ortho bonding, or is there any other indications not to do pre-orthodontic bonding?
The one time when you don't want to do pre-orthodontic bonding on a patient is when it's going to make them really look ugly. So VME is one of those times, but also when a patient has dentoalveolar extrusion. Can y'all see my picture? Are you seeing my picture?
We're seeing your slide with your information.
But are you seeing me?
Yes, we are.
Okay, so if you've got a patient that has dentoalveolar extrusion and their teeth are super erupted, their front teeth are really super erupted, and they have that concave gingival line, and their front teeth are very low in their smile, you wouldn't want to, but they're worn, so they're only 7 or 8 millimeters long. You wouldn't want to do pre-orthodontic bonding on that patient because you would make their smile uglier. So when the teeth are short and they're up and they're little, those are perfect people for pre-orthodontic bonding. When the teeth are too low in the smile, we don't do pre-orthodontic bonding. We move the teeth back up first, then do the bonding, then put the braces back on to finish the case. So that's really a very good question.
Okay. Questions about coding, time allotted for doing these bondings, and what do you basically bill them as?
All right, so insurance has nothing to do with anything I talked about today. So I think we just have to make that clear. In the United States, insurance is good maybe for $1,500, and the things I'm showing you are not about $1,500. Now, one thing is the aesthetic crown lengthening. Aesthetic crown lengthening is for one thing, and that's aesthetics. There's no periodontal disease, and therefore very seldom will insurance pay for aesthetic crown lengthening. However, if the patient really wants you to send it in, to submit it to the insurance, you could submit it as 2 quadrants of osseous surgery, because that's what it is. But I never have any assumption that the insurance is going to pay for the aesthetic crown lengthening. It's a cash deal, generally speaking. All right, what about the bonding, pre-orthodontic bonding? So when I present a treatment plan to the patient, the treatment plan is going to have everything on it that I'm going to be doing on that patient for the next 2 or 3 years. So I am quoting fees for the porcelain veneers I'm going to be doing 2 years from now. I'm quoting those fees right now, and I will honor those fees 2 or 3 years down the road. So on my treatment plan, at a minimum, it's going to have pre-orthodontic bonding, and then it's going to have porcelain restorations at the end. Now they understand the fees associated with the pre-orthodontic or with the veneers, but what about the pre-orthodontic bonding? That doesn't make any sense to them. So I explained to them a couple of things. When we do the pre or intermediate orthodontic bonding, the first thing is you're going to really enjoy it because it's going to make you look better. And that is a cool part about it. They are almost always thrilled when they start with short teeth and they have normal looking teeth before the braces ever go on. The second thing I tell them is that by making the teeth anatomically correct, it's going to shorten the time that it takes to get the ortho done because it's a much more clear-cut orthodontic treatment that way. And I say to them, I have to be honest with you, at the end of ortho, you're going to be sick of it. You're going to be sick of your braces. You're going to want them off. And if we can shorten the time it takes to do the ortho, then you're going to appreciate that. The third thing is it puts the teeth in exactly the correct positions. So at the end of ortho, I can then do the beautiful and functional restorations that you came for me for. So that's what I tell the patient. Those are the 3 reasons we're doing it. I quote a fee for them, and they know what it is. It is a fee per tooth. And I think everybody has to figure out what that fee should be. I mean, a fee should be determined by how long it takes you to do it and what your overhead is. So I'm not supposed to talk about fees, in front of everybody across the world, but let's just take a theoretical. Let's just say to make this work for me financially, I would pick a number like $200 a tooth. So if it took me an hour and a half or 2 hours to do 6 front teeth, then that would be $1,200. So if you felt like that was fair to you, that for your skill, talent, and judgment to do those bondings in an hour and a half or 2 hours for $1,200, then that would be a fee that would be appropriate for you. So I think you have to have a belief that it's worth it, and you have to help the patient understand that it's worth it, that this is a significant amount of money, but it's a requirement in order for us to get the result that we want at the end. I hope that answered the question.
That's perfect. Thank you very much. What is the material for the clear matrix you use, and what kind of worm composites do you like?
Okay, so I use the clear matrix material I use is called Memosil 2, Memosil 2, made by Horace Kolzer. There are a bunch of them out there. The reason I like Memosil 2 is because it's fairly rigid. And the more rigid the material, the better. So it is a clear bite registration material called Memosil 2. The composite warmer that I use, it doesn't make any difference. There's one that's made by Addent, A-D-D-E-N-T. That's a good one. I use one that's sold by 3M that goes with the BioClear system. I've become a BioClear fan. And so the composite heater that I use is the one made by 3M for the BioClear system. It heats the composite to about 155 degrees. You can also just warm water up in a microwave, make it so hot that you can't leave your finger in it. You can put your finger in it, but you can't leave it there, and put the composite compules in that. And that will heat the composite up nicely also.
Thank you. Okay, would the patient's continual tooth eruption after implant placement be stopped by simply using a night guard after implant placement?
That's a definitive no. We have no way to stop the alveolus from growing. So a night guard, an Essex, they will not keep the alveolus from growing.
All righty. Lots of questions regarding the Maryland Bridge there. I'm sure glad you showed it, but the questions are, would anti-rotational grooves cause caries on abutment tooth? Would you use this technique for a missing central incisor? Why don't you use 2 wings? And what cement would you use?
Okay, so that's a lot of questions. So the first question, the reason we only use 1 wing instead of 2 wings is because the literature is replete with studies to prove that. So that is just based on science. 2 wings are not as successful long-term as 1 wing. The second question, would I use it to replace a central incisor? Yes, I would. If the occlusion were favorable, I would rather have a Maryland Bridge in my mouth than an implant, especially if I were young if the occlusion would allow for it. The third question was, am I worried about decay in the groove? No, I'm not worried about decay because it's bonded. The only way you could get decay in the groove is if the wing came off. And if the wing comes off, the bridge falls out and the patient's going to come in immediately and get it replaced. So I have no concern about decay in the retention grooves that I put in the canine. Here's the other deal. Let's say that it comes off every 3 years. The patient just isn't gentle with it, and every 3 years it comes off, and they finally say, I've had it, I want an implant. You say, fine. You know, when we first put it in, you were 25, and now you're 40, so that's good. You know, we got some years out of it. Maybe it won't grow. And so we put the implant in. What do we do about the groove on the canine tooth? We fill it in with composite. I mean, that's all there is to it. So I don't have any concern about cutting the groove into the canine tooth, because if I ever had to restore that, I would just do it with composite. The last question that I remember was, what material do I use? And it has to be a dual cured resin cement with MDP in it. MDP is a magic monomer that bonds beautifully to zirconia. And there are several products out there that have MDP in them. The one that I have chosen to use because the research supports it very well, number one, and number two, it's the one that I've had the best success with. I've used two. The one I've had the best success with is Panavia V5, not Panavia SA. That's not good enough. Panavia V5 is their Mad Dog dual cured resin cement that works beautifully for bonding zirconia. So did I get all those answers?
I have to say that was an amazing display of listening to questions, and wow, your wife must be very happy with you. You're a good listener. All righty. In regards to veneers, how do you recover from veneer failures on lower anteriors? How about upper veneers into dentin? How much dentin is okay? And do you have your veneer patients wear a bite guard or Essex nightly?
Okay, first of all, Essex or night guard, yes, that's pretty much a standard for me, unless they're wearing a mandibular advancement device, which is a whole nother deal. But if they do not have sleep disorder breathing, then they're going to be wearing an Essex or a night guard, yes. How much dentin is, well, let's see. How do we recover on lower incisors with veneers that have failed? And the answer is, you either go to ortho and do it the right way and then come back and restore them with full coverage, or you over prepare the teeth and do full coverage as they are. So when you have veneers failing because of a dentin substrate, then you're done with dentin, which means you got to go to full coverage. Commonly, you can improve that situation, however, with ortho. The other question was, what about uppers? How much dentin is okay? And upper teeth are different than lower teeth. And it's pretty common for me to get a little dentin exposed in the gingival third. I'm not a no prep veneer guy, so I prep upper teeth for porcelain veneers. But my goal is to be in enamel 100%. If I'm, let's say, 90% in enamel and I have 10% dentin exposed in the gingival third, as long as the margin in the gingival third is still in enamel, I feel golden. So it's not so much on maxillary veneers how much dentin, it's where the dentin is. If you have dentin exposed, a fair amount of dentin exposed centrally, but you've got good enamel at all of the margins, then you have a much greater chance than if you've got dentin exposed peripherally. So the place in my career where I've seen the most failures of my maxillary veneers is when I have a fracture in the gingival third of the veneer, and that usually happens over quite a number of years because it fatigues. The veneer was bonded to a dentin substrate all the way to the gingival margin, and eventually it fatigues to the degree that you get a little half moon fracture of the veneer in the gingival third. So the answer is, it's not really whether you've got 50% enamel and 50% dentin. The answer is, where is the 50%? And if you have 50% enamel peripherally, you're a whole lot better off than if you got 50% enamel, but you got 50% dentin peripherally.
So lots of questions regarding crown lengthening, but does aesthetic crown lengthening lead to recession later on?
Okay, the good news is that the answer is, we're dealing with biology, and so there's no always or never, but almost always the answer is never. As I said, I've been doing aesthetic crown lengthening now for 30 years. So the first question is, why does the patient need aesthetic crown lengthening? And the answer is because their biotype is too thick. And we never really have to worry about recession in patients that have thick biotypes. It's patients with thin biotypes. And so the patient with altered passive eruption right off of the bat, just biologically, isn't the kind of person that gets gingival recession. Some surgeons move the bone 3 millimeters apical to the CEJ on every patient, which means that they're going to put the tissue right at the CEJ post-op, and they're going to maximize the length of the tooth. That's good. But the problem is that if over time there is just a little bit of apical migration, then all of a sudden the CEJ and the root are exposed. Therefore, I'm more conservative. And that's the reason I don't move the bone 3 millimeters apical to the CEJ in the normal crest patient. I move it 2 millimeters apical to the CEJ, and then I put the tissue 3 millimeters coronal to the new alveolar crest, which means the CEJ will be a full millimeter subgingival at the end. So that is not a common outcome of aesthetic crown lengthening. Gingival recession over time is a very uncommon outcome of that procedure.
Well, we've spent 2 hours together, Dr. Robbins. Thank you again, sir. I know you're extremely busy. It was very, very kind of you to donate your time. Thank you for being a good friend to the IAG, the Canadian Academy of Restorative Dentistry and Prosthodontics, and the AGD. We really appreciate it. I have one last question for you. Are you teaching clinical crown lengthening aesthetic courses?
I am, and I mean, I know you don't want me hawking my stuff, and that's the reason I.
No. We've got a lot of people asking about that. So
I do teach a clinical crown lengthening course with my periodontist. His name is Eric Rendler. We do it about every other year, and he teaches a day of connective tissue grafting, and I teach a day of aesthetic crown lengthening. And we have one of those courses coming up in San Antonio in November of this year, assuming that we can get together. So once again, if a person is interested in what I'm teaching, you can go to my website, robbinsdds.com, go under teachings, and you'll see an icon that says upcoming courses, I believe it is, and it will have some courses that I will be teaching in the next year. And again, I mentioned the study club that we've just started. That won't be on the website because literally we have just launched it. So if anybody's interested in the virtual study club, which we're going to call Global Diagnosis Education, then just send me an email and I'll send you the information about it. So thanks for asking that, Tim.
Okay. And one more shameless plug, please, for the Operative Academy.
I would be happy to do that. I hope we get to meet again. That's my hope. I hope that we'll be able to meet in large rooms in February. One of my most favorite organizations of my whole career is the Academy of Operative Dentistry, and it meets in Chicago in the same weekend as the Chicago Midwinter meeting, and it meets on Thursday and Friday. And it is the most inclusive of all big organizations I've ever been a part of, and I've been going now for more than 25 years. Every year the program is amazing. It is among the best of all of the programs that go with all the meetings that go on during the Chicago Midwinter meeting. And I would encourage, assuming that we get to meet again, it is not a very expensive meeting. You get a ton of information over 2 days. It's one of the best meetings in dentistry. So thanks for bringing that up. I wish I'd thought to plug it myself. The Academy of Operative Dentistry. Just go I think it's operative. Let's see, what is the website?
It should be like AOD, operative. Oh,
It doesn't matter. Just
just
Google
go
it.
to Google.
Yeah, Google Academy of Operative Dentistry. One of the
All
best,
right.
the best
Yeah.
of all meetings for sure.
Yeah, that meeting changed my life when Dr. Hoffman and Hasegawa invited me to it. So, well, thank you very much. To the rest of you out there, our next speaker is going to be on at 12 o'clock noon PST time. So, oh, and the link is over for the Academy of Operative Dentistry over in the chat feature there. Dr. Robbins, you can go ahead and sign off. I'm just going to share my screen here for a second with some more information for people with the upcoming speakers.
Okay, and Tim, thanks for what y'all are doing for all these. That is a wonderful thing for dentistry. Thanks for what you've done. Good luck, everybody, on reentry.
Appreciate it. Take care. All righty. For those of you that got into the meeting a little bit late, there was a little confusion there, but that's okay. Dr. Robbins webinar will be up on YouTube here within a couple hours. Just go to Washington Academy General Dentistry look for that channel, like, subscribe, ring the bell, and you'll be notified every time a new webinar is up there. If you want to register for any of the upcoming webinars, we've got another 13 this week. Go to washingtonagd.org and just look for the WAGD Stay Home, Stay Healthy CE series, and you'll be able to scroll down and get registered. Keep in mind your CE credits are going to be coming from the University of Washington School of Dentistry CE department. Those should appear in your email box in the next 2 or 3 days. It will be a PDF. Please save a copy of that PDF. For those of you that are AGD members, we'll report your CE credit directly to the Academy of General Dentistry. You won't need to do that. Again, a big thank you to the International Academy of Nathology for putting today's speakers together. Neil Grassetto follows here at noon, and then at 2:30 p.m. we have Thomas Giblin joining us from Australia. So great lineup. And we'll just let some of these flyers go by so you can see the speakers that Arkansas AGD has put together for us tomorrow. Fantastic. If you like sleep apnea stuff, you'll want to catch Dr. Metz and Robley. And then on Thursday, the Canadian Academy of Restorative Dentistry and Prosthodontics have put together 3 speakers for us as well. And don't forget to join Dr. Manu Karbash on Friday. She's got some strategies to help us ease back into our offices after the COVID-19 pandemic, or for us here in Washington State, May 18th. A reminder that there will be some more webinars coming online here next week. We're just trying to figure out the speakers that we're going to have, including Markus Trosch from Germany, who will be speaking on PPE and aerosols in the office. And we're going to be lining up some other helpful speakers from Patterson, hopefully Terry Harris, some staff management stuff, and so we're just putting those speakers together. So we're not done yet. Thank you for joining us, and we will see you at noon.
Thank you, Dr. Hess.
You are welcome. We can go ahead and end this meeting and get the other one started.